Well, thank you for the introduction. Again, my name is David Brennan, and it's my honor to provide the Eileen O'Brien Memorial Lecture and provide a talk and hopefully a lively discussion about breast cancer prevention. And I'm told this is supposed to be more like a conversation at a dinner table, but I'm going to try to be less tangential than I might normally be at dinner. And I wish I could stand up here today and tell you that there's this thing that one could do, or a intervention that you could take, or food that you could eat, or an exercise you could partake in that would prevent someone from developing breast cancer. But as we've heard earlier today, you know, when we talk about cancer prevention and breast cancer prevention included, we're really talking about risk reduction. So before we talk about that, let's kind of figure out what the risk of developing breast cancer is. So the American Cancer Society today estimates that about 1 in 8 women will develop breast cancer at some point throughout their lifetime, and that translates into a risk of 12% lifetime risk, assuming women live to be in their early 90s. So 12 in 100 women will develop breast cancer at some point throughout the point of their life. And as physicians, people who treat breast cancer and see high-risk patients, when we talk about risk reduction strategies, we really divide them into 3 overarching categories: modifiable risk factors, medications, commonly known as chemoprevention, and risk-reducing surgery or prophylactic surgery. So let's start off by talking about lifestyle modifications. These are kind of the ones that are easier to use. There are 3 lifestyle modifications that are generally accepted to reduce breast cancer risk, and one is alcohol consumption, the other is increasing exercise and weight control. So unfortunately, at least for me, because I do enjoy having an alcoholic beverage occasionally, alcohol consumption has been, in pretty much every study evaluating it, been clearly associated with an increased risk of developing cancer of all kinds, including breast cancer. And in the case of breast cancer, that association is what we call dose-dependent. And what that means is that if a woman averages 1 alcoholic beverage a day, her risk of developing breast cancer increases by 10%. If she averages 2 drinks a day, it goes up by 20%. If she averages half a drink a day, it goes up by 5%. So if we can reduce alcohol consumption or curtail it completely, we can decrease the risk of developing breast cancer on a populational level, and in this way, prevent breast cancer. Exercise is another modifiable lifestyle risk factor that we can look at. Unfortunately, exercise is not quite clearly as associated with breast cancer risk reduction as alcohol is, but for women who report that they exercise regularly, there have been studies to show that there's up to a 30% reduction in risk of developing breast cancer. And weight control, especially in the postmenopausal period of one's life, has been shown to decrease breast cancer risk by up to 2.5-fold. But obviously, these are easy things to do. These are the low-hanging fruit, if you will. And there's no significant side effects of these things, other than probably it increases your overall health, even if it didn't decrease your risk of developing breast cancer. And that probably means that it makes sense to do these things: decrease alcohol consumption, exercise more, and watch your weight for almost every patient. But the impact on risk reduction for breast cancer is modest. So what are the high-impact strategies? Well, in general, there's 2 high-impact strategies. One is known as chemoprevention, and what that means is you take a medication that would reduce your risk of developing breast cancer, and the other is prophylactic surgery, and in the case of breast cancer, we're talking about a bilateral prophylactic mastectomy. Now, obviously, those things are a big deal, and those are not the answers for most patients because they have side effects. All medications have side effects, including the medications that we use for chemoprevention for breast cancer. And obviously, surgery is a very major step to take to reduce risk. So it probably makes sense to try to identify the patients who are at highest risk to develop breast cancer and then consider these very significant interventions for them more than for the person of average risk. And how do we do that? We talk to patients. We figure out family histories. If there's a family history, a significant family history of breast or ovarian cancer, we worry about a genetic predisposition to develop breast cancer. We also try to find out if there are any personal non-modifiable risk factors, such as a history of abnormal breast biopsies, increased breast density, a history of radiation exposure. And then we use this information and we plug it into epidemiologic models and we calculate an individual's 10-year risk and lifetime risk of developing breast cancer. And in doing so, we can find very high-risk patients. And if you think about it for a minute, does it make sense to give an average risk woman give her a medication to reduce her risk that has significant side effects, or even consider prophylactic surgery? We have medications now that can reduce the risk of developing breast cancer by nearly in half. So where is there going to be the highest impact? Is it going to be the highest impact on women that we talked about of average risk, a risk of 12 out of 100 women of developing breast cancer? If we give her that medication and reduce the risk in half, we're going to prevent 6 breast cancers per 100 women treated, and all 100 women will suffer from the side effects of that treatment. But if we can identify a group of women who have a 50% lifetime risk or even an 80% lifetime risk of developing breast cancer, and we give 100 women with that level of risk that same drug, we're going to prevent up to 40 breast cancers. So it probably makes sense to do it in that situation, especially on a societal level, where we can reduce breast cancer incidence substantially and still accept those side effects. So I mentioned genetic testing. When does it make sense to consider genetic testing to try to identify patients who are at the highest risk to develop breast cancer, patients who carry a BRCA1 or 2 mutation? And we look at family history. If there's a family history of early onset breast cancer, a personal history of breast cancer and ovarian cancer in the patient or other family members, a history of bilateral breast cancer or breast cancer on both sides, or a family history of male breast cancer, it makes sense to do genetic testing to see if you can identify women who are BRCA1 or 2 mutation carriers. And that's because women who are BRCA1 or 2 mutation carriers are at a 50 to 85% lifetime risk of developing breast cancer. They're also at an increased risk of developing ovarian cancer, in the 30 to 40% range lifetime risk. And for other members of the family, there is an increased risk of developing prostate cancer, colon cancer, pancreatic cancer, and skin cancer, all of this associated with BRCA1 or 2 mutations. I mentioned before history of non-modifiable personal risk factors, such as having undergone a breast biopsy that showed abnormal cells, such as atypical ductal hyperplasia, lobular carcinoma in situ, or other things that we call cytologic atypia. And these can increase the risk of developing breast cancer by up to 8 or 9-fold for some individuals. Radiation therapy, usually to treat cancer, often as a child for Hodgkin's lymphoma, especially when the patient underwent that treatment in her teens, also can result in a substantial increased risk of developing breast cancer, and in some patients as high as 20 to 30-fold increase in risk. So these are truly high-risk patients, and it makes sense for these high-risk patients to consider these more radical risk-reducing options that I briefly mentioned before, like chemoprevention and prophylactic mastectomy. In the United States, there are 2 drugs that have been approved for chemoprevention, and these drugs reduce the risk of developing breast cancer on average about 47%, and in some instances in the high 80% range. Those drugs are tamoxifen, raloxifene, and then there's also a drug that hasn't yet been approved by the FDA called exemestane that is also equally and maybe even a little bit more effective. So I also mentioned surgery to reduce risk. So this is probably the option that we reserve for women at really the highest level of risk, because it's obviously not the right decision for everybody, but the level of risk reduction enjoyed by women who undergo bilateral prophylactic mastectomy is substantial. Reduces the risk by 90 to 95%, and what that means is that while the risk of developing breast cancer after undergoing this surgery isn't 0, it approaches 0. But again, it's obviously not the option for most women. So to kind of sum it up, when we talk about breast cancer prevention, like all cancer prevention, what we're really talking about is risk reduction. And for breast cancer, we're going to do that through modifiable risk factors, hopefully for most women, through alcohol consumption, increasing exercise, weight control. And then for women who are at the highest levels of risk, we're going to consider medications for chemoprevention as well as prophylactic surgery. And it's this way that we can prevent breast cancers, decrease the number of breast cancers, because not having cancer is better than being cured of cancer, clearly, on a populational level. So thank you for your attention, and I'm happy to answer any questions.
Thank you, Doctor. Does anybody have any questions? Anybody have any questions here? Dr. Nancy Ray, please stand up.
I have a question. Clinically, I ended up seeing as people were able to obtain health care, we were talking earlier about the numbers of people when they finally have access to health care, that there's a surge in diagnoses because there's been a delay. Mm-hmm. Is there any statistics on when people did receive health care more recently in the that we had a surge or any kind of an uptick in terms of diagnoses or late diagnoses?
Yeah. I'm not aware of these specific statistics, but I can tell you that I have experienced this very thing with breast cancer. So when national health care was available, we certainly saw an increased number of women who were diagnosed with relatively late breast cancers, an uptick, because if you think about it, when we're screening for breast cancer, the whole idea is to catch the breast cancer at its earliest stages. And if you suddenly provide screening services to women who could not receive them before, you're going to, for a period of time anyway, probably a 3 to 5 year period of time, you're going to identify a higher proportion of women who will present with later stage cancer. So that's definitely something that I have observed in my practice lifetime. And I'm sure there is data in the mammography realm showing that, but I can't quote that data off the top of my head.
Thank you, Doctor. We have one more question from Dr. Sherman.
In gastroenterology, we have patients with ulcerative colitis who have to have a total colectomy, where you remove the whole colon as cancer prevention or when we think they might be developing cancer. And we often find, not often, but we do find in that specimen previously undiagnosed cancer. When you have women who elect to have bilateral mastectomy prophylactically, do you actually find cancer cells within that breast tissue on occasion?
Certainly on occasion that occurs, but we really do everything we can to not be surprised by that. Because the operation that we do for women who have a prophylactic mastectomy is a little bit different than the operation we would do for someone who has breast cancer. So typically before we embark on a prophylactic mastectomy, we're going to screen that patient with imaging pretty intensely. And often these patients have been screened during their life up to that point intensely because they're high-risk patients. So in other words, we're going to get the best kind of mammograms that we can get on these patients, and we're going to get breast MRIs on these patients. But despite all that, sometimes we are surprised and do find cancers in the breasts that we remove prophylactically. But we definitely try to avoid that. It's less common, though, than
Thank you, Doctor. Our photographer here has a question. Quickly, we have a schedule here because we have a panel coming up. Quickly.
I had heard about weight being
Yeah.
a part of cancer. I was just curious where the scale is weight issue.
Yeah. So again, the association. Some studies have shown there's an association. Some studies have shown there is not an association. And remember, these are associations. It's not causality that we're able to show at this point. Although there is plausible causality. Adipose tissue in postmenopausal women produces estrogen. That's the only source or the primary source of estrogen in a woman in the postmenopausal period. So the more adipose tissue someone has, the higher the estrogen levels will be in the body that breast tissue is exposed to. And in some studies, as I alluded to, the level of risk reduction was seen most profoundly if the patient gained weight in the postmenopausal period and it was not on hormone replacement therapy at the time. So again, the data isn't quite as clearly associated as alcohol consumption, but it's generally accepted that weight control probably reduces breast cancer risk, especially weight control in the postmenopausal period of life.
But I think, too, that people understand that obesity is a cancer risk for many cancers. And it's good to hear about that. We had one more question back in the red coat. Did you have a question? Did somebody have a question back there? No, I thought you were raising your hand. So, Doctor, we wanted to thank you very much for your help and being here today. Thanks so much for everything.
My pleasure.
Thank you very much.